background. And part of, obviously, our commitment to our referral hospitals, and certainly as a St. Vincent Health facility, is ongoing education. And this is something that Deb had asked for in terms of how do you know when a baby is just making some transition issues versus, well, this is more than that. So this is Dr. John Wareham. I'm sure a lot of you know John. He's certainly
Been here forever.
And John and I worked together for a long time. He was at Methodist, and I was at Methodist. And so anyway, so he's going to review, I think, some of those key points that you wanted us to talk about. And please, if there's something that, you know, a particular case that you remember or any kind of question, don't hesitate to ask. This is the perfect forum to do this. So,
All right, well, I brought two presentations. One is a short one talking about when to send a baby, and which I think is frequently a discussion point, and then how you know when a baby needs to be transferred for respiratory distress, and while you're figuring that out, what is reasonable to do at your institution. And are there any respiratory therapists here?
Yep.
Good, very good. And then while we're doing that, we'll talk a little bit about CPAP and high flow nasal cannulas and so forth. And then if you do want to talk about any specific illnesses, I've got a mega talk that I stole from my wife on respiratory therapy, on respiratory issues in newborns, that we can look at x-rays and talk about anything you want to talk about. But I thought that it would be maybe of more interest rather than going through the usual 6 or 8 respiratory causes of respiratory distress we deal with, just talk about how you stabilize newborns that have respiratory distress, what you use, what's reasonable, and then when you know to give them the boot. And if you have particular questions about individual babies or individual problems, we can talk about them. And I'll probably ask you a little bit about what equipment you have here. And one of the things I'd very much like to know is if there's something you don't have, you need. And
See you later.
give me a list. Well, even in these wonderful healthcare times, you have to have an advantage for belonging to a big system. And if there are things that don't meet the minimum need that you need, that will help you get them. All right, so respiratory distress in the newborn, evaluation, stabilization, and the timing of transfer, and most of this is talking about timing of transfer. Hit the right button. I want one of these screens for home. Evaluation. So for term and near-term infants with respiratory distress, really one of the real problems we have is figuring out, is this kid going to get really sick, or is this just a baby that's sort of staggering through transition, and with a little time and a little of doing the right things, the baby's going to be fine in a few hours. So many of the kids that do develop respiratory distress in the delivery room, a number of minutes to a few hours later, they're going to be fine. And then, but sometimes it is hard to sort out those kids, and every now and then you're going to take a kid into the nursery who you think is going to be fine, and they're going to tell you over the next minutes to a few hours that no, I'm really not, and I'm really sick. And that happens to us too. You know, we put babies that are grown in the delivery room. They go either to the neonatal intensive care unit or to our continuing care nursery, which is sort of a triage transition unit. And we guess wrong all the time where a baby that goes to our critical care, our continuing care nursery, which is not set up for any CPAP or positive pressure support, just oxygen, whether you do a cannula or a hood. And the baby says, you know, an hour after they get there, I really need CPAP. And then they have to come down the hall to the NICU. And it's exactly the same sort of thing that you're having to try and figure out is only, you know, you've got to send them further than down the hallway. Now, if the infant is preterm, and depending on how preterm, that's a little bit of a different animal. And if you have a preterm infant in respiratory distress, that baby probably needs to go to a neonatal intensive care. Because the possibility you're dealing with respiratory distress syndrome, and that may need positive pressure support, whether CPAP or a ventilator, because the typical course for respiratory distress syndrome is for it to get worse over the first few days of life before it starts to get better. You know, you definitely have to worry about even if the baby is manageable right now. If the baby's preterm and it's respiratory distress, it's going to get worse. The other thing is preterm labor is frequently triggered by some sort of infection, and certainly a preterm baby with respiratory distress probably has a higher risk of there being an infection involved, which again can lead to a baby that's pretty sick. So a lot of what I'm looking at is those kids that sort of 35, 36 weeks and above, when do you send them out the door to your referral hospital? So, questions that you can sort of ask yourself, is this, you know, you're looking at this baby, is this a baby that can stay in my institution? This baby has just been born, they're grunting and groaning, you're giving them a little supplemental oxygen. Things that, again, important, like we were just talking about, is how premature is this baby, if they are premature? Is the baby normally grown? And if the baby's got respiratory distress, is this a baby that's just, you know, grunting intermittently? Or is this a baby that's retracting hard and really working hard and, you know, 50% oxygen? So, you know, how the baby looks is important. Although, again, you know, I've sent enough babies to the NICU that look fine 2 hours later, who look like they were gonna, you know, have to get intubated in the delivery room, and 2 hours later they're ready to eat. You know, it just, none of this is an exact science. And then a very important thing is, as you watch the baby, are they staying the same? Are they getting worse? Or are they getting better? And that's going to be something that really factors in all along as you're making that decision, trying to figure out how is this baby changing. And if it's a baby that has some significant respiratory distress, which you think are getting better, then you may, that's somebody you can watch for a little bit. If they're staying the same, well, you know, that you can still probably watch them for a little bit, but they're clearly getting worse, that's a bad thing. And then if you're going to watch them in respiratory distress for a little bit, what are you going to do to support them while you're watching them? What is your capability? You use an oxy hood, a nasal cannula, CPAP, high flow nasal cannula. So, I thought this was a very commonsensical article because, you know, when I go and look through the literature looking for things like this, there isn't much written, which is really too bad because this is something that every place that doesn't have a level 3 or 4 nursery has to deal with this. And people really haven't studied this very well, which is too bad. But this is something that came out of the Journal of Family Medicine in 1998. It came out of Iowa. And one of our nursing educator in the NICU is from Iowa, so I told her this was the only article ever published from the state of Iowa. But this wasn't so much science as trying to put a commonsensical approach together. And Iowa has a pretty good perinatal system. They have a state perinatal program that staff are pulled from a number of different institutions to help I think on a yearly or every 2-year period, they go to every hospital and ask them what, do a little survey, find out what they need, what things they would like to have for education, what support they need for different things, and see if they're, and also looking at if they're operating at, the level of care they think they should be at. And I think it works pretty well. So every delivery service in the state of Iowa is part of the program, the Iowa Statewide Perinatal Care Program. And again, everybody is staff that do the annual or every 2-year surveys are all people in perinatal care. They're obstetricians, pediatricians, obstetric nurses, neonatal nurses. And as part of that program, they put together a set of clinical guidelines to help physicians decide whether a newborn with respiratory distress could be managed locally, or whether the baby needs to be transferred. So just as a review, before we go on and talk about their 2-hour rule, just a quick run through of the common respiratory distress causes in newborns. And under the lung or pulmonary issues, we have pneumothorax, transient tachypnea of the newborn, meconium aspiration. Now, meconium aspiration is interesting because we don't see that very often. I think probably once a year we get a real rip-roaring meconium aspiration baby. And sometimes they're inborn, sometimes even on transport. And which is interesting because we really almost never suction the airway anymore. In our peak guidelines now, the baby comes out and it's vigorous. And just no matter how pea soup it looks, we suction it out when it's happy. So why do we not see much meconium aspiration anymore? Very good. Okay. Yes, and so that is on the trail of the answer. What's the answer? You're close. I don't like giving credit to people from Iowa, and I really don't like giving credit to obstetricians. But in obstetric care, we don't get meconium aspiration syndrome very often because obstetricians are, generally we have good prenatal care in the population we see, not 100%, but pretty good. And we don't have post-dates, and if babies are having trouble in the womb, then they come out of the womb, and the moms get the care they need. So this is something that obstetrics has really made an impact on. We don't see much meconium aspiration anymore, and that's really good, because that is miserable disease.
So you're saying that it's more intrauterine than it is
Yes.
postpartum?
Yes. And the bad meconium aspiration syndrome was always, the majority of that was intrauterine. That very few kids ended up in a lot of trouble because they aspirated at delivery or in the delivery room. The vast majority of the kids that had horrible meconium aspiration and pulmonary hypertension